$699. Acute utilization was 21 versus a budget of 21, so we hit that. Hospital operating visits was 562 versus 617, which is 45 less than budgeted. Assisted living is at 82%. The non-skilled swing beds was 482 versus 426, which is above. And the skilled swing beds was 58 versus 42, which is also above. Therefore, we made 42,000 revenue above there because of the skilled and non-skilled beds.
Inpatient seems to be doing pretty well.
Last month.
Last month.
Not this month.
As you heard, they just got a new member in. There, so that should help it there. The payroll is still over a budget, but because of contracts, which has to do with your next gen area and the DIDA. Saying it wrong.
Monida.
Monida. Okay. And that's pretty well what I got out of the meeting.
Does the finance committee have a recommendation?
Just one correction, just a numbers correction on what Lloyd said, and then I'll move approval. Actually, the difference between the 54 and the 31 is 23. $23,000 improvement on the loss. And with that, I'll move we approve the report.
Second.
Okay, any further discussion? All in favor of approving the financial report?
Aye. Aye.
Any opposed? I don't think there was any. Okay, let's move on to our fiscal year 2013 audit and cost report in progress. When are the
Yeah.
auditors going to be out here? Have they already started?
They'll probably be out here
Usually
next
December.
month.
December.
And right now, we're preparing for that, but we pretty much, right now, what we're preparing for is the cost report, to get that done, and that's imminent, that we need to get that done. And the good news on that is that the cost that we incurred in putting together, you know, the feasibility study, the architectural fees and those kind of things for the new hospital are going to be able, since we've abandoned that project, we can now put those on the cost report and get some reimbursement back for those costs. We should.
I don't know if
should
I'd
be-
say abandoned as much as put on hold.
The term is abandoned.
Get it on the cost
We
report.
want it on the
Medicare.
cost report.
Really?
It's a ban.
Yeah,
Is
we
it
want
really?
it on the cost report. That doesn't mean we can't start a new project
Right.
next year.
A couple years down the line, get
Yeah.
everything in order.
Abandoned.
Abandoned, that just
That's
sounds
a bureaucratic term.
sad.
You gotta live by it.
That doesn't.
We're
mean-
not gonna do it next year, though, anyway, I can tell you that.
So are we expecting, so in January, then we will probably have the auditors here to go over the report with us?
Yes.
Okay. Is that it?
That's it.
Any
for me.
questions about that?
Nope.
Okay. Cash flow crisis team.
Well, I kind of talked about that with Cindy. You know, the team is, I formed it right away. Everybody on the leadership team except Kirsten, she needs to keep things rolling with patients on the floor, and that's not her bag anyway, so. You know, the other four of us, I guess, 1, 2, 3, 5, 5 of us, I guess, with me. We meet once or twice a week, you know, sometimes a little smaller group than others, you know, depending on schedules, but the first thing we did really was to get Stacy to send around the daily cash balance every day, so we all knew, you know, what was going on. But, yeah, we should probably let, or are you gonna do that later? No, why don't you talk, Deb, about, you know, about the good news that we've had, you know, certainly in terms of cash flow and stuff.
Okay. So, the end of October, our AR days, accounts receivables days, were at about 91. As we look at them today, and it's always a moving target, we're at 78. we have posted over $600,000 in cash this month, in November, so.
Cash
that-
received.
Cash received
Right.
So far.
so far. We still have, a few days.
Is that
And if I called over right now. it'd
mainly
probably
from
be
Medicare, or is that some?
Medicare, Medicaid.
From all sources?
All
sources.
sources.
Okay.
One thing we've noticed is, as we've had a spike in credit card payments, our self-pay person is really trying to get as many accounts off the system as we can, leading into moving to next gen. And so, we're trying to work very hard with patients to get those old accounts, self-pay accounts off the system as best we can. So that, that's great news for us, 600,000, I don't know. The bigger issue is, though, keeping our volumes up and making sure that we have revenues coming in the door so we can continue to do that. Where, as you get your AR days down, you have less cushion of bringing in that old money.
Mhm.
And so that's why it's so important to not just look at, what cash we have coming in, but how do we make sure that the volumes are up there and that we can continue to make those revenues to get the cash back in. And so, do you want to go through a little bit of that, Larry, or?
Well, yeah. Oops, we did this with the finance committee, but maybe just taking it to the next step. That cash that Deb is talking about, we put it to good use in terms of the payables balances. This is the payables balance, just like yesterday, I guess. And then Quality Systems is the next gen electronic health record contract. Commitments and billings, it's all lumped in on the payables report. And almost $500,000, that's being funded with the capital lease, that Cliff has talked to you before about. So if you take that out, and it's the more traditional trade payables, and again, these are floating numbers. There's some nuances in these numbers that I don't want to go into, or we'd be here all day, and you don't want to listen to that stuff. That's an approximate payables balance of true payables at this point in time. At this point in time. And so if you take, this is the day that I started, it happens to be, but right after that, Stacy was really able to pay down, some of these payables. And if you take the balance up here, on a month ago, and you subtract today's balance, we have made this much improvement, so we've used some of that cash. The danger with this story is that, next week, or right after the first of the month, we're going to get another $170,000, $200,000 worth of, I don't know the exact number, but we're going to get a big chunk, a big dollar amount here for the next, for the payables that we've incurred last month. So it's, it's important that we get those numbers down as soon as we can with that plan, by the first of the year, so that we can reduce this amount that comes in every day, and stuff. It's Stacy's feeling that she made a little bit of progress, but it's, we're not. This isn't the true progress that we've made on the payables, but. We have to have something to look forward to this month. And we did do a lot. We did accomplish a lot. This is a lot. To drive your payables balance down for a month. So it's just a fluid situation. But we, just to show you that we are making some progress on it, a little bit. And I don't.
And we did it without drawing on the line of credit.
That's correct.
That's
correct.
That's really good.
We did not have to go to the line of credit, and we did not have to go to the tax subsidy too either. That's coming in now at the end of the month. So so we have some options, in terms of the future cash flow. But again, I don't know if I said it in this meeting, but our payroll runs 200,000, round numbers here again, but 200,000 twice a month gross, and the payables 170, 200 plus. plus. You know, there's some things in there that, you know, some of the payables reflect withholdings, you know, on, you know, insurances and other things, you know, like taxes that, well, you better pay that or, you
Yeah.
know, we'll all end up in jail.
Yeah.
Or I will.
They get cranky about it.
Yeah, they do, you know, we always, of course, pay those. But it's a little bit hard to explain it, you know, in the payables amount. It's not really true payables, trade payables, you know, in the traditional sense. And I don't know if, this might just confuse everybody, you know, and stuff. I think we've talked about the accounts receivable enough. Maybe the gist of it is that, you know, yeah, this is the number of accounts receivable, but that was early, and we made progress. You know, the 600,000 that Deb has talked about brings it down. Then there's a bunch of self-pay, slow pay in here, about 500,000 of self-pay, slow pay, we call them. And we're working hard after the electronic health record. We've got a lot of work to do there. Kind of a second priority, an immediate priority right after that is we're going to try to get this 500,000 off our books. There are companies out there that will work those for you, not just write them off, but we write them off and they're off our books. And they should be, because they're not really payables that are paid within 60 or 90 days, you know, they're not. So there's
Are we seeing a lot of community anger or bad feelings in the way that we're working with those old accounts? Or has it been,
No.
okay.
no.
I just want to make sure we're not going to
No.
get angry letters.
And that is a danger.
You know, I-
Turn it over to people.
I think
That-
we
And that's
have,
one of my concerns.
yeah, we have some confusion of,
Sure.
of what's going on, but I think people are getting their bills more timely. Insurance companies are paying their claims more routinely. We always have some outliers
Sure.
that don't like to pay and, you know, require a whole bunch of work to do that, but, and.
But so long as
and
we're
I
not,
think
I've never
people
got a
are-
bill for 6 months and all of a sudden I'm
Yeah.
getting a bill that says that I'm way overdue.
No, I
That's happening
haven't
on the
heard
clinic
any of
side.
that
I
from
know,
the
are we
hospital side.
being a little bit.
Not on this
Yeah,
side.
not from the
Sensitive.
hospital
I haven't heard
side.
any of that on the
Okay.
hospital side.
You know, we have some old accounts that we've resolved,
Mhm.
that I think have been real blessings for some of our patients, that we're looking at some real high self-pay balances that they could have ended up with, and Wanda has worked really hard to help get some Medicaid assistance to some of those
Good.
people, and paid down some of those accounts, and, you know, that's all part of that money that's
Good.
coming in, so.
And this thing is just kind of shows, you know, yeah, you're looking at this big number, but there's a number of explanations. Well, this is actual cash. And, you know, this is not really, to me, really a 60 to 90-day payable. This self-pay, slow pay, and we're going to work at trying to get that into a different process so that we can get it off our books and show the more correct balance in a very general way. It's not an exact number, but in a very general way, is more realistic, really, for this size facility. That's very realistic, if you know, to deal with. Actually, we wish it were a little higher, you know, because then it gives you more cash flow. And also, you know, this stuff kind of comes all back around and it's billed again.
Have
you
the
know,
days be lower, but the amount be higher, right?
Yeah.
Yeah. So is there are there other meaningful things that have come out of this cash flow crisis team? Things that have been implemented, or is this just a matter of monitoring the situation?
Oh, you mean I call them money savers? Is that what you're asking? Money?
Well, yeah, or
Well, there's
what's
many.
the purpose of the cash flow crisis team?
Well, it's to identify that, and we've started that line-by-line analysis that I'm talking about of ways to reduce those obligations.
Okay.
And to reduce them and cut them back, both operationally and increase cash, you know, from Deb's activities in terms of billing and stuff.
Well, if there's no further questions, sorry, I'm trying to
Oh, I'll
move
get-
this along. I'll keep you moving, Larry.
All right.
can we move on to our CEO report from Larry? Let's talk about our communication work plan.
Can I sneak?
Did you have some-
cut ahead so I can go? Is that
Right, yeah, I was
I
just
have to get
gonna
back to
suggest
clinic.
that.
Yep.
So, what are the things to report for us? Med staff has done we did like a dinner meeting with our Yellowstone, insurance that Kirsten helped set up about documentation and reducing legal risk, recently this last month, a couple weeks ago. We're working hard on going live with the next gen EHR in the hospital, and thankfully for the providers, I think we have the easiest piece of it, so that's a good thing, we're glad about that. Also, in working with Cindy and Larry, on improving communication, I think with providers and in general, what's going on in finances and all those things that we didn't really have much information about before. And working together, I think I can speak from med staff that the two of them work very well collaborative on making sure things are taken care of on all levels and keeping us in the loop and keeping us informed. And I think we'll have our plan, I hope, of by January 1. I think that's doable, and I think it's getting back to that this is a business and we have to run a profitable business, or at least try to make it be as profitable as we can. And through that, I think some stuff is hard, but it'll be better in the long run. I think all of us are on board with that. And we're looking forward to improved communication with board and all that kind of stuff. So I think communication has been the biggest good for us out of all of these things.
In line with that, thank you for being here. I'm so glad that you're here and we're gonna have a med staff participation. Because there hadn't been a lot of communication with that, and we want, as an ex officio member of the board, we need your input as well as we're trying to make decisions.
Yeah.
So, just thank you for being here.
Yeah, we're excited. And we're very excited to be a part of it, and be a part of strategic plan and anything that you
Yeah.
want us to do. We're happy to do it. All right, I'm
Is there
sorry,
anything
today
else?
I'm back to clinic.
Okay, thank you.
Thanks.
Thanks, you guys.
Thanks, Laurel.
Yep.
Okay, let's talk about communication work plan.
I just put it in there, really, I circulated, I think, earlier with you folks, and
Sure.
You had asked me to do that, and I think that's pretty key that we, open up those lines of communication. I think we've talked enough about it, you can certainly see that we're doing
Yeah,
that.
and it's nice to get it intermittent, not just once a month at the board meeting, but it's nice to get updates on things as they go, some of the key.
One thing that I haven't had time to do, and I do like to do it, and I hope that I can get it done pretty quickly, is that CEO update report, and,
Yeah.
get that around, about some of the key things and stuff, and
Yeah.
circulate around, so. We'll continue working on that. Last night, Cindy and I went to the chamber meeting. Let's see, we've been to the commissioners, I think, 2 or 3 times. She's been separately, I was there twice, and so we've been getting around the community as much as we possibly can. And our own, I met with I think I put that in the report
Yeah.
before, internal and external both.
Okay, dashboard report.
Oh, well, now, Kirsten said I had to give the dashboard. Well, a lot of the indicators, I think, are more administrative in nature. I think that's why she was suggesting that I do that, and I'm used to that from Livingston and other facilities. I really don't want to walk through and take the time to walk through each one of these, but I think most of the statistics would show, were probably discussed by Cliff or myself in our discussions, anything that's out of the, maybe I'll just highlight the red ones. There's a couple of red ones. I mean, we've already talked about days cash on hand. Oh, that's really, that's ugly. That's ugly when it's 18 days.
The ED 72-hour concerns me.
Where are you? Let's see.
At the bottom,
At the bottom.
the patients return to the emergency.
Yeah, that's not a good number. I don't know why. We'd have to. Well,
Amy,
Kirsten.
Your clinical outcomes committee
Mhm.
is addressing those in
Okay.
detail.
That's
And
what I
so-
figured, that's why I wasn't gonna.
Yeah, those are gonna
hammer
be,
on it.
eventually, those will be tied to payment, as you're probably aware, in,
Right.
right, later on.
Right.
Of course, the average, if you look at the year average, you know, it's two. But, and sometimes there's medical reasons too for that too, right? I mean, there's legitimate medical reasons why they might return to the ER.
And that's what your clinical outcomes committee will review in detail.
Great. One of the ones that I was concerned about was the number of observation hours. We've had some discussion. Dr. Pafford actually wanted some more information about when that occurred, on which shifts, if we can determine, if we can take some corrective action on that. That also, it probably doesn't concern Kirsten and the medical staff so much, but it concerns the billing folks a lot, because the feds have gotten really difficult with the way they pay. There's a lot of things that have to happen there in terms of documentation and stuff, so we'll be following up with that one for sure, because it affects this stuff. It affects this
More is
stuff.
better or less?
Less.
Less, okay.
No, yeah, we want that to be
We want less.
0.
Observation
What was
Admit 'em.
hours?
What was it? It was like
Wait, wait,
126,
wait.
is that what it, is that what
No.
we're looking at?
Not the
I'm
observation
being
hours.
flip here.
Oh,
There are
okay.
many reasons why
Oh.
you don't why you don't admit a patient, but there are many reasons, and it's very complicated medically. But
So I'm looking at our benchmarks 185.
on the number of observation
Am I
hours.
looking at the wrong
Yeah.
thing?
Yeah.
Oh, it is. It
I mean,
is.
if the benchmark's
Oh, okay.
185, do we have the wrong benchmark for one?
Possibly,
If-
Amy, and the reason is this is the first year that we've started measuring observation hours.
Okay.
I asked for it to be measured because it increases your nursing workload.
Oh,
Okay.
And so I
absolutely.
just wanted you to get a number on it. So we kind of took a guess
Oh, okay.
on our first
I
benchmark.
thought, well, if that's where we
Yeah.
were in, if we're lower, if lower is better, then why are we red?
Lower isn't necessarily better. It's all based on the patient's condition.
Right.
Okay.
Right.
So how do we
We
get
the-
meaningful information?
The billing
from-
folks would look at it differently than the medical folks. You know.
So what is this, how is this meaningful for us to take to look at? I guess, my question. Because I see red on, if I see red on here, I'm like, oh,
Right.
pay attention, you know? But I don't always know what meaningful information I should be getting from
It'll be a
that.
tough one to look at, because if you see all of a sudden your observation hours are dropping down into the 10s or 20s, and you see that your returns to ERs are up in the 8s or 10s,
Mhm.
then that will
Yeah.
tell you that maybe that provider should have placed that patient in observation
Instead
rather
of
than
sending
sending
him
him
home.
home and trying to arrive at what the correct level of care for that
Sure.
patient would be. And at the
Makes
end of
sense.
that observation stay, then perhaps the provider will discharge the patient home, or maybe they'll admit them to the hospital. But the observation, that's where the provider doesn't really know what's going on with the patient, yet they need to keep them under nursing care observation and provider observation in order to determine that.
Yeah, really
And so
good
you'll see,
explanation, Kirsten.
I would expect for you to see
That's good.
observation hours to go down as admissions go up,
Mhm.
because the provider then was able to make a definitive diagnosis on the patient and admit them for care, rather than needing more information. and
So
yet
are
having
they
them-
actually admitted for observation?
Yeah, we call it placed in observation.
And that's what this represents.
Mhm.
So if you, on the second one in there is green, it says 240. Follow me?
Yeah.
Now, is that 240, does that represent, will the number of patients under observation?
No, it's hours.
That's
Hours.
hours
It's hours.
of different patients all added
Yeah.
up.
Yeah.
And so
Under
one
observation.
patient, it may only take 8 hours for the
Yes.
provider to determine that their chest pain was not cardiac related, and so that patient will be there for 8 hours. But the next patient, it might take up to 24 hours to determine what's causing that patient's abdominal pain. And so it's very patient-specific as to how many hours
But
they're
it
in
is the
there
cumulative number for all patients.
for all observation
There are
patients.
observations.
That's right.
So when I look at this at, 126, so that comparatively, is kind of low. if you look at the previous 5 months, there's one that's lower. But then you jump down and you see that there were 4 patients that returned within 72 hours. And in some respects, that would be tied together, that maybe there was,
Maybe.
You know,
Maybe.
it could be, that's what your clinical outcomes committee is going to be looking at on those 4 cases. And often, you know, I will hear the providers even in peer review say, well, perhaps that patient should have been placed in observation rather than sending them home.
Sure. Okay. That was my question about dashboard. Are there any other questions about the dashboard report? Okay, well, let's go on to our leadership advisory committee report from the innovations.
Yeah, I did sit in on a telephone conference call. You know, the Innovations Grant is working with 25 critical access hospitals across the state. And I sat in on about an hour and a half conference call with those 25 CEOs, my colleagues around the state, with the leadership on the Innovations Grant, those folks. Good conversation. Talking about what's happening and what's going on with the, I always forget what the, TNA's title.
Better Health
Better Health
Improvement
Improvement
Specialist.
Specialist.
Better Health Improvement Specialist, thank you.
HIS.
Yeah, and it was a really good conversation. And also some other things that are happening with iVantage and some of their data that they're getting back. There is some concern, I guess, frankly, with the fairly sophisticated level of that data, whether it's really applicable to real small frontier critical access hospitals. There's been a lot of concern about that by some of my colleagues around the state. And that came out from that conversation. But the innovations crew is really an exceptional group. I've worked in the past with Faith Jones, who is one of their sub-awardees, excellent person, really understands critical access hospitals, and they're working through these things to make. They're having some summits with their sub-awardees and their folks to make sure that those kinds of issues that are surfacing from the CAHs and from the BHISs
So what is
are getting addressed.
What are the issues that have surfaced here?
None here that I know of. These were, we've been so involved with some of this stuff, and also
High priority, yes.
right, and also the with Tanai, also the implementation of the electronic health record. He's been very involved with that. I don't think he's really stepped into those issues too much at this point.
Well,
One thing I did talk to Tanay about was after he gets free from this, I really would like to see him look at the a lean. He's really good at lean,
Right.
and that's a perfect project for that. Well, there's a lot of things that you can certainly do with that, but getting rid of the waste and the inefficiencies and the unnecessary steps, if there are any, in terms of par levels and inventory levels in central supply, which I think needs some attention here. And I think there's some real cost savings, and we can do that fairly quickly, I think. It's great to have him be able to devote some attention to that, but he's going to be real busy with with that one, with the electronic health record with Deb and Kirsten, for a little while here.
There was someone that had a comment? Did you have a comment?
Oh, I was just gonna say, part of pulling him into the implementation of the EHR is so that he can sort of know those processes and work some lean stuff as we're going along and building. So in a sense, he's not totally focused on one lean project, but his input in helping build the system hopefully will get us some efficiencies, and that was really our goal in putting him in that EHR process as well.
Okay. Okay. Is there anything to add? I think we talked about the health center collaboration.
Right.
And town hall meetings and,
Right.
the Elks Association grant request, what was that?
Yeah, we just want to let you know that we're going to apply for an Elks Association grant. It's a small grant, it's a great program, they've been around for a long time. That fellow that kind of runs that program is up in Glasgow, Montana, and he's done it for years and years. But they gather funds from around the state, specifically for small rural hospitals for a piece of life-saving medical equipment. And, you know, Kirsten's familiar with the program, I think Deb too. And we
So
spoke
it's like
to
an
him.
equipment grant?
Yeah, usually it is, not always, but yeah, exactly. And we talked to the Kirsten and the medical staff. I think you've gotten to, well, we did. We talked to the medical staff yesterday about it. They want a BiPAP machine, which they really have wanted for a while. And we're pinning down the exact cost that.
It's around $4,000, and that very piece of equipment, Manny is trying to bring in this next week to see how it works
Oh, okay.
as a loaner.
Oh, great.
And so it is in the capital budget. We did get it there as well. So
Oh, okay.
we're moving forward with that, and it is less than the $5,000, which is good.
You know,
I
there
checked
are
with him
different
yesterday on
bells
that,
and
yeah.
whistles
That's
apparently
right.
on these BiPAPs. And
That's
and
true.
Kirsten indicated yesterday that they may want and they may have patient need for the bells and whistles that might cost a little bit more than that.
Oh,
So,
okay. Yeah.
we'll work that out. But just to let you know that we're working through the process, and I have the application, and we will get it off, even in this busy time, if we can provide a piece of life-saving medical equipment at no charge. That's pretty important. So.
Well, can you tell me what the function is?
I was gonna ask the same
A
question.
patient who can't breathe on their own and requires someone to breathe for them. Currently, we use a bag and manually push it, but this machine will do the breathing for them. And so we can transfer that that patient by ambulance ground and have that machine do the breathing rather than requiring another ambulance crew driver.
So
Go
this
along and
machine
provide
is
it.
portable.
Mm-hmm.
Kinda like a-
Sometimes isn't it described as a portable vent? I mean,
Yeah.
You
Yep.
know, I've heard it described
That's
as, from a
such a
layman, that's a
basic
little
need.
easier to process than
Like a portable iron lung.
Right.
Yeah.
Right. Called a portable vent sometimes.
Yeah.
Wow.
Okay, thanks.
Ventilator, portable ventilator.
Thank you, Larry. DNS report, Kirsten, let's talk about the next gen go live preparations and,
Okay.
or if
don't-
somebody else wants to take that one,
Yeah,
but,
I don't know quite what to tell you about that. We recently had our mock go live, 4 days. We had next gen folks here, and I guess I'll just say it's been the most positive experience that I've had with next gen since we began working with them. I
is
couldn't
that the good, or
believe-
does that mean it's been really?
I just couldn't believe how much.
No, it was great.
we
No,
were
not this one, but
confident.
historically, has it been very challenging?
Yes.
Okay.
Extremely
Yeah.
challenging.
Just want to put it in perspective.
Is it better than the rollout and aftercare
Roll out where?
on
what?
Obamacare?
Oh, yeah. So how we did it is we ran through a scenario, and every time we ran into an obstacle in that scenario, the next gen person would write it down. And then at the end of that scenario, they would send it to the fix-it team, and the fix-it team would work on everything. And then we'd run through another scenario. Did it get fixed, yes or no? And then each scenario just got a little bit smoother. There were still some big things that we need to work out, but this team was really strong. They were really working hard.
And where's this team?
They come from all over,
Do
mostly
they?
from Texas.
Yeah.
A lot of them from Texas.
You would not believe the amount of money that's sitting in the room when they're doing this. It's
I
just
believe it.
Yeah,
How many
it
were
was
here?
great. Probably a dozen,
Yeah.
10.
15
Gee whiz.
Yeah.
This is all part of the
maybe. Right.
agreement
Part of
that
that
we have.
487,000.
Yeah,
plus.
it better be.
Yeah.
That's part of that
292.
one day. Oh, no, not that one.
Make us do this, they better give us support.
Yeah, I kept looking around the room.
So go live, that's set for the 3rd, December 3rd,
Second, yep.
2nd? Mhm.
Are you satisfied
Are
with
we
it so far?
confident?
The status?
We are going to have a discussion at 3:30 this afternoon with NextGen. about whether that's the right go-live date or not. So we will know at the end of the day whether,
Okay.
whether we need to.
Because we're bumping up on some deadlines and stuff
Yeah.
as far as meaningful use,
Yeah.
right?
We were not able to successfully get a bill off the system during our mock. So we need to have some discussions unless we've been able to really make some huge progress. We may be looking at delaying that a bit. Now,
Yeah, we can't.
we've also had conversations yesterday and again this morning. We had a conference call with the state, making sure that we do not lose any meaningful use dollars.
Mhm.
The first time we delayed it, there was some dollars that we lost out on. The delay, if we do it again this time, we will not lose anything more than what we've lost. Part of that is because our fiscal year does not end until June 30th.
Mhm.
So we will know better this afternoon what we're shooting at. If we can delay it and if that's workable with Next Gen and the powers that be, we will probably be looking more at mid-January for a go-live date.
Okay.
Jan? Oh, you're looking at.
Yeah, Next Gen wasn't available to us in December so